Good morning, students. Today the topic is host modulation. Host modulation. These are the on to the introduction. As is the case with any other disease, periodontal disease is also basically the end result of interaction between three factors, which is host, bacteria, and environment. Like example, smoking, medications, or faulty dentistry. Moving on to the past era, which is the history of host modulation. Understanding of etiology and pathogenesis of periodontal disease focused on the microbial aspect. So periodontal disease was an inevitable consequence of aging and was uniformly distributed in the population. So this disease severity directly correlated with. And coming to the non-specific plaque hypothesis to specific plaque hypothesis, disease progression was considered to be continuous, linear manner throughout life. And the therapeutic efforts were focused mainly on mechanical or chemotherapeutic removal of. But the fact is there are two categories of patients, which is periodontal disease resistant and periodontal disease susceptible. So periodontal disease resistant people had abundant plaque, calculus, gingivitis, some shallow pockets, and there were no signs of deep pockets and bone loss. Whereas periodontal disease susceptible patients were having good oral hygiene, minimal plaque, deep pockets, mobility, and aggressive bone loss and early tooth. The difference and why is the response is so different in different individuals. So that was the question which was arising in the past era. So they were considering a lot of solutions and they have arrived at a paradigm was shifted and the notion came to like periodontal disease is not a natural consequence of aging, whereas periodontal disease is not related with the plaque levels as far as severity is concerned. So pathogenesis of periodontal disease focuses not only on just microbial aspect, but an important role is being given to the host response. It's a role of host response where it's the roles are role in protection as well as in destruction. So there came the need to modify or modulate host response and development of host modulation therapies to improve therapeutic outcomes, slow the progression of disease, and allow for more predictable management. So coming to models of periodontal pathogenesis, initially in 1916, Lowe et al. Was the first one to come up with a linear model. Linear model is nothing but a direct model where there is no reversal of any part in that model. So that's why it is called as linear model. And next, basic conceptual model by Sirka model in 1981, critical pathway model, non-linear model. Non-linear model was the one which changed the game, which was given by R.C. Page and Conman in 1997. So this is a revised model of basic conceptual model which was given by Lowe et al. In 1960. And next is multi-level hierarchical model by Conman in 2008 and biological system models by Offenbaker in 2008. So this is basically the main model which was given by Conman in 1997 is a non-linear model of host modulation where initially microbial challenge when it is acting on a host or any human body, it will be given antigens and lipopolysaccharides and other virulence factors. Any bacteria like for say P. gingivalis will be giving gingipains and all those virulence factors. For as response for this microbial challenge, host immune inflammatory response will be giving antibodies and PMNs for response to the microbial organisms. So and if it is not subsided with the host immune inflammatory response in the primary stage, then for the secondary stage, it will move on to production of cytokines and prostanoids and MMPs, which will directly affect both host as well as the microbial organisms. And as it is affecting the host also, it will lead to connective tissue and bone metabolism damage. If in this stage also the host is keep continually producing cytokines and prostanoids and MMPs like such as pro-inflammatory mediators, and this will lead to the clinical sign of disease which is called as periodontal disease. So in this whole model, both genetic risk factors and environmental and acquired risk factors plays a major role where that decides whether the disease is reversed or the disease is progressing. So that's why this is called as non-linear model because there is a chance that the disease can be reversed. Okay. And this is where the balance exists between the host and the microbial organism. So when this balance is maintained, the host will be modulated in a healthy state, whereas when there is an imbalance between the disease and health state, there will be a bacterial higher level and we will be getting periodontitis. So in disease state, the factors are risk factors like smoking, diabetes, genetics, and overproduction of pro-inflammatory or destructive mediators and enzymes like interleukin-1, interleukin-6, PG2, TNF-alpha, and MMPs, and underactivity or overactivity of aspects of host response, poor compliance and poor plaque control, and substantial bioburden. Whereas on the other side, if the patient has to be maintained in a healthy state, then there should be reduction of risk factors such as smoking, diabetes, and genetics. and also expression of host-derived anti-inflammatory or protective mediators such as interleukin-4, interleukin-10, interleukin-1, RA, and TAMPs, and host modulatory therapy and resolution of inflammation, OHI, which is oral hygiene inspection, SRP surgery, antiseptics, antibiotics to reduce the bacterial challenge. So this balance has to be maintained throughout the life to prevent from periodontitis. So the definition of host modulation, host is nothing but an organism which a parasite derives its nourishment, or the individual who receives a graft, or in relation with periodontal diseases, an individual who harbors pathogens associated with periodontal diseases. Moving on to modulation. Modulation is nothing but an alteration of function or status of something in response to a stimulus or an altered chemical or physical environment. In terms of periodontal disease, host modulation means altering the host or host periodontal tissue reaction to the bacterial challenge. So coming to the proper definition, which is given by William et al. In 1990 and Golub et al. In 1992, host modulation therapy is defined as a treatment concept that aims to reduce tissue restriction and stabilize or even regenerate the periodontium by modifying or down-regulating destructive aspects of the host response and upregulating protective or regenerative responses. So basically, HMTs are systemically or locally delivered pharmaceuticals that are prescribed as part of periodontal therapy and are used as an adjunct to conventional periodontal treatments, which is your scaling and root planing as well as your periodontal surgery. So since we have already seen in the previous slides regarding the balance between the host and the microbial disease, so when this balance between periodontal health and disease, when the health is diminished, the periodontal disease, which is persistent microbial burden and upregulation of destructive immune inflammatory response is higher, there will be chances of periodontal disease. Whereas when there is a resolution of inflammation and down-regulation of destructive process, the patient will be made in a healthy state, which is a non-periodontitis. To rationale of host modulation therapy, historically the treatment of periodontal disease has focused on reducing microbial burden by better oral hygiene, scaling, root planing, and periodontal surgery. But in the context of present knowledge of pathogenesis of periodontal disease, the conventional treatment targets only one aspect of pathological process, which is reducing bacterial load and antigenic challenge. Coming to rationale of HMT are to downregulate destructive and upregulate protective aspects of host response, to modulate periodontal tissue response to bacterial challenge, to stabilize or regenerate periodontal tissues as an adjunctive treatment, and to act as a risk. Coming to classification of different host modulation therapy, on the basis of the mode of action of host HMT, it is classified. First, inhibition of MMPs, which is CMT, chemically modified tetracycline. STD, sub-antimicrobial dose doxycycline. We will be discussing about this deliberately in the later slides. And second is inhibition of arachidonic acid metabolism, which is your NSAIDs, COX-1 inhibitors, COX-2 inhibitors, COX and LOX inhibitors, and modulation of bone metabolism, which is given by bisphosphonates and hormone replacement therapy. And fourth one is regulation of immune and inflammatory responses, which is given by suppressing pro-inflammatory cytokines, your interleukin-1 and TNF alpha, or nitrous oxide inhibition, generation of protective antibodies through vaccines, or infusion supplementary anti-inflammatory cytokines, interleukin flow and interleukin. Moving on to anti-inflammatory drugs, the development of all periodontal disease is a consequence of the inflammatory and immunological reaction of the host to bacterial plaque. Any drug that has an anti-inflammatory products therefore should be capable of modifying the host reactions to the bacterial insult and so have clinical effect upon the progression of disease. To pathway of arachidonic acid metabolism, this is where the phospholipids, or which is your lipopolysaccharide, are converted into arachidonic acid and giving your PG2 will be giving leading to the formation of thromboxane, prostaglandins, and prostacyclin. Prostaglandins are nothing but synthesis from arachidonic acid by all mammalian tissues cells except. So prostaglandins were first discovered by von Ariel in 1939. PG2 has been extensively studied in periodontal disease and is considered as one of the most potent prostaglandins that upregulates bone resorption by osteoclast. PG2 also inhibits fibroblast function and has an inhibitory and modulatory effect on. So enzyme COX, which converts the arachidonic acid into PG, exists in two isoforms, which is COX-1 and type of NSAIDs which is used in host modulation, or your traditional NSAIDs like salicylates, propanoic acid derivatives, or COX-2 inhibitors like nimesulide, meloxicam, COX-2 inhibitors like colecoxib and etoricoxib. Studies have shown that systemic NSAIDs like fluviprofen and indomethacin and naproxen were administered up to 3 years significantly slowed the rate of alveolar. Coming to disadvantages, For clinically apparent periodontal benefit, NSAIDs need to be administered daily for a long period. Can cause GI problems, hemorrhage, renal and hepatic impairment, etc. So the rebound effect will be periodontal benefits of taking long-term NSAIDs are lost when patients stop taking the drugs with a return to or even an acceleration of the rate of bone loss seen before NSAID therapy. The administration of selective COX-2 inhibitors results in reduction of periodontal inflammation without the side effects observed after long-term non-selective NSAIDs. They also modify the PG production and also slow alveolar bone loss. However, selective COX-2 inhibitors have been identified to be associated with significant and life-threatening adverse effects because of which these drugs have been withdrawn. Inference: NSAIDs including COX-2 inhibitors are presently not indicated as an adjunctive HMTs in the and moving to your bisphosphonates now. Bisphosphonates, these are non-biodegradable bone-seeking analogs of pyrophosphate that have a high affinity for calcium phosphate crystals and that inhibit osteoclast activity. Most of actions of bisphosphonates are mainly osteoclastic-centric, which will do inhibition of development of osteoclast, induction of osteoclastic apoptosis, reduction of activity of osteoclast, and prevention of the development of osteoclast from hematopoietic precursors, stimulation of production of an osteoclast inhibitor. So coming to classification of bisphosphonates, first generation bisphosphonates, second generation bisphosphonates, and third generation bisphosphonates. Examples are etironate, which is first generation. Second generation examples include alendronate and palmitoronate, and third generation bisphosphonates include triethronate. And bisphosphonates are used in metabolic bone disorders, example tumor-induced hyperglycemia, osteoporosis, Peter disease. And animal studies have revealed increased bone density and decreased bone resorption in case of periodontitis when treated with bisphosphonates. In humans, enhanced alveolar bone state. Coming to unwanted effects with some bisphosphonates, which will cause inhibit spleen classification, induces changes in WBC counts, avascular necrosis of jaws, in some cases with risk of post-extraction necrosis, and presently not approved and indicated for the treatment. Coming to your STD, which is sub-antimicrobial dose doxycycline. The treatments include STD, periostatin US, Canada and Europe, modified release STD. A long-term use of full standard dose of doxycycline, which is 100 mg, can have ill effect on body, prominent brain superinfection and renal. A 20 mg dose of doxycycline, which is periostat, approved and indicated as an adjunct to SRP in the treatment of chronic periodontitis. So dosage schedule, which is 20 mg twice a day for 3 months up to a maximum of 9 months continuous dosing, and presently the only systematically administered HMT for chronic periodontitis approved by US FDA and accepted by ADA and UK Medicines and Healthcare Products Regulatory Agency. A modified release STD has been recently approved by FDA for the treatment of common skin disorders, rosacea, to be used as an adjunct to SRP and not as a standalone therapy, which is more. And moving to mechanism of action, in addition to its antimicrobial property, doxycycline has the ability to downregulate MMPs, especially MMP8 and MP9, and reduces cytokine levels and stimulates osteoclastic activity and new bone formation. So this is mainly the full chart, which how your STD is acting on host modulation, which will directly include inhibition of production of epithelial-derived MMPs and direct inhibition of active MMPs, scavenges and inhibits production of ROS and produced by PMMS, and inhibition of MMP and ROS protects proteinase inhibitor and reduces osteoclastic activity and bone resorption, blocks osteoclast MMPs and stimulates osteoclastic activity and bone formation. Coming to doxycycline, doxycycline has been confirmed to be more effective inhibitor of MMPs than either minocycline or tetracycline. Doxycycline has much low inhibitory concentration than minocycline and tetracycline, indicating that much lower dose of doxycycline is necessary to reduce a given collagenase level by 50% compared with minocycline and tetracycline. Doxycycline has been found to be more effective in blocking neutrophil collagenase activity, which is your MMP8, than fibroblast collagenase activity, which is your MMP. Coming to indication of STD as an adjunct in chronic and aggressive periodontitis, refractory periodontitis, especially in smokers, periodontitis cases associated with risk factors like smoking and diabetes mellitus, and patients with periodontitis associated genotype, which is PAG, and they have specific variation in genes that regulate interleukin. These are the classification of MMP. Moving to inhibitors of MMPs, we have PMPs, alpha-2 macroglobin, CMPs, and STDs, and tissue inhibitors of metalloproteinases, which is your TMPs or food variants, and alpha-2 macroglobin protein present in blood, which is antiprotein. And coming to functions of MMPs, the main function of MMP is to catalyze the breakdown of protein in cell plasma membrane or within the extracellular matrix, which is remodeling of extracellular matrix. They also play an important role in tissue remodeling in physiological or pathological process, example morphogenesis, angiogenesis. In periodontal disease, MMPs play key roles in degradation of extracellular matrix